everyone, and welcome to episode 33 of CCA's Medical Minute podcast, sponsored by Kroger Health. We are honored to have with us today Dr. Robin Zahn, who is a medical oncologist and hematologist with Michiana Hematology Oncology, and she is she would be too humble to tell you herself, but she is a former member of ASCO, right?
I'm still an ASCO member.
You still are?
Absolutely.
Okay, which is American Society of Clinical Oncology, and she was a recent winner of their Distinguished Achievement Award. Mm-hmm. So congratulations on that, even though it's a year or two ago. But so welcome.
Thanks, Steve. Thanks for asking me to join you today.
Yeah, no, it's been fun. So we're also really happy to have Jill Hunt with us today, oncology nurse practitioner, who is my sidekick most of the time. Mm-hmm. Every once in a while. I think you got 2 weeks off, though?
I think I did.
Yeah. All right. Well, you're back.
We're going to have to do some bunk bed chairs or something.
Exactly. First time I've worn this tie today. Combines three of my favorite things: breast cancer awareness, prostate cancer awareness, and bourbon bottles.
Bourbon bottles?
There's bourbon in there.
Those are bourbon designs?
That's right, exactly.
What would make it even better is that if you had all of those things and it was a bow tie.
Ooh, I do. Well, they make a bow tie. I may get that.
See?
That's a good point.
I'm just
because I have matching
feeding
socks.
into the...
Anyway. Dr. Zahn, most important question I'm going to ask you all day. Where in the world is Michiana?
Great question. So Michiana is an area of the country that borders northern Indiana and Michigan. I arrived there and it was already called Michiana, and it's an area that includes South Bend, University of Notre Dame.
There we go. Okay.
For those domers, as well as Southern Michigan.
Gotcha. Well, we get occasional sports reference. Jill has an axe to grind, I think, with Michigan for some reason. I don't know why, but
not that I have an axe to grind. It's just we live in Ohio,
well,
so
that's fair.
I mean,
Fair point.
and in all
right.
fairness, I mean, it's kind of required that you're a Buckeyes fan. Well, if you're a Buckeyes fan, you can't really like Michigan.
All right, first real question. So you are a medical oncologist and hematologist, and so this is just my own curiosity. So oftentimes you'll see that someone is a medical oncologist and a hematologist. I don't think that's always the case, but why is that often the case? Why is a medical oncologist oftentimes a hematologist? You see them combined in practice groups and things like that.
Right. And you're exactly right. Especially in the past, the medical oncologist also used to function as a hematologist. So hematology is actually a group of diseases that includes non-cancer type of blood problems, such as sickle cell anemia, for example, or bleeding disorders. But then the vast amount of hematology that we see are those that are cancerous. So it includes lymphoma, leukemias, multiple myeloma. Nowadays, what we're finding is that the diseases are so complex with regards to solid tumors, which is mostly medical oncology, and hematology, which we call liquid tumors, that we now are starting to separate because it's too hard to keep up on all the nuances.
On everything.
Yeah.
Yep.
Correct.
Yeah, that makes sense. So I knew you were going to, we were going to talk about genetics today, and I know that you had a question for her about BRCA1 and BRCA2.
Yeah, so obviously with cancer care and the more educated patients are getting, there's more and more focus on cancer genetics. And even people who don't have a cancer diagnosis know or have heard of BRCA1 and BRCA2. What are the cancers where inherited genes play the greatest role?
Right. So typically inherited genes play the greatest role in cancers that besiege a family. So there may be multiple cancers or a single cancer that's a particular family. So for example, I was describing to Steve earlier today that I have a family I take care of 5 siblings, all women. And 2 of them had breast cancer that were early on in their presentation, ovarian cancer, colon cancer, which is loosely associated with one of the BRCA2 genes, as well as pancreatic cancer. Wow. And so in that particular family, they in fact were positive for a BRCA gene. Sometimes we see patients who are first presentation. In other words, they have a cancer and you decide you're going to check them because of their Ashkenazi Jewish descent. Yep. And we do know that there are some ethnicities that may be related to certain genetic diseases, and we're learning more and more about that as we start to understand ethnicity and how that plays into genetic disorders. So there are multiple cancers. In fact, there are so many different platforms that there are some platforms that have multiple cancers, including prostate, brain cancer, and a number of other cancers, and it won't be BRCA. So we are learning about all these different genetic types now that may confer an increased risk of, not a definite a definite sentence that you're going to get cancer, but increased risk, which then helps us be better doctors for screenings and surveillance.
Yeah,
Right.
that makes sense. So when we did talk earlier this morning, you used a term I really hadn't heard before, but you were talking about a class of drugs, and you referred to them as anti-genetics. So can you tell us a little bit about what that means?
Right. So just to be very transparent, anti-genetic drugs is not an official term. That's a Robin Zahn term.
I Googled it. That's why I was going to ask
There
you.
you
I'm
go.
like, I can't find what
No,
that
you're
means.
not going to find it unless you go under my name. And the point is it's a way to explain how the drugs work with patients. So the bottom line is that there are certain cancers. We'll take BRCA because that's the most well-known and the most studied, and the one in which we do have a drug. And the drug that I tend to use quite a bit is generic Elipramab, and it's also called Lynparza. And the way it works is it interferes with the actual genetics of the cancer cell and does not allow it to become cancerous and to multiply as it generally does in patients. So there's a genetic pathway that occurs within these cells, and this is very high level and not very scientific, but at the end of the day, it interferes with that and reverses the ability of the cancer cell to repair itself and to continue to grow.
Interesting. So one of the things we really haven't talked much about, or really hardly at all, because we started this podcast last November, and September is Ovarian Cancer Awareness Month. So we're kind of coming up on when we will be talking about that. But May 8th was World Ovarian Cancer Day. And so I did want to touch on it briefly because you and I had a brief conversation this morning too, that we're still not at a point where we have very good, effective screening tools for ovarian cancer, which is often found late. Is there anything, are you seeing anything on the horizon that might lead to a new discovery there or a new tool, or we just kind of, is it just kind of, it is what it is?
Right. So the short answer is there's still research being done to try to discover a tool. We don't have any very good effective screening tools. However, we can stratify individuals. So if we have patients that are BRCA1 or 2 positive, we know that they have high risk ovarian cancer. They may see their gynecologist more frequently for the typical screenings, which may include a blood test as well as a pelvic exam and an ultrasound. But what's coming forward is the role, still not totally described and understood, of looking at what's called circulating tumor cells in the blood. And there's a lot of research being done by a number of companies that are saying, you know, for high-risk populations, if we stratify somebody with a strong family history of ovarian cancer with or without a genetic disorder, or somebody who has a BRCA1 or 2, perhaps there's a test that we can do that's a blood-related or a saliva test that we may be able to determine that there is a DNA identification of a cancer cell that we don't know about. So that's still research to be explored, but it is not standard of care and it is not offered routinely at this time.
Gotcha. Well, at least that's an encouraging possibility, if nothing else.
Absolutely.
So in the absence of a really effective screening tool, can you talk a little bit about, have you seen an improvement in the therapeutics to treat ovarian cancer? Are you seeing better results and better outcomes with that?
Absolutely. Just in my lifetime of 30 plus years of taking care of cancer patients, you know, the standard of care usually involves surgery, and even the surgical approach has changed now, so it's not so debilitating and recovery is much quicker, as well as something called infusional chemotherapy during surgery that's been helping a number of women. But outside of that, when they see the medical oncology, we still use chemotherapy. But the good news is, in my perspective, if patients are BRCA1 or 2 positive, and even those who are not, we now are using these drugs that I mentioned, the anti-genetic drugs, which are also called PARP inhibitors, PARP, PARP inhibitors, for maintenance. And in my own patient population, I am just seeing incredible lengths of periods of time remaining cancer-free after initial therapy and chemotherapy. And we might be preventing other cancers that are associated with the BRCA as well. So that's really exciting for me to be able to witness that. Because when I first started, 30-some years ago, and saw ovarian cancer patients, what we call stage 3 disease, which is, we hope is curable, but really isn't, high chance of relapse, we're now seeing them have extended survivals and feel great.
Okay.
Yeah.
All right.
So we mentioned that with the BRCA gene earlier, how people assume that those play just a heavy role in these inherited cancers like breast and ovarian. Can you speak a little bit about how likely these types of cancers are to be inherited? In other words, like if a patient has a BRCA mutation, are they condemned to the fate of absolutely having a cancer diagnosis?
So that's a great question, because when people find out that their families are carriers of something like BRCA, they often become very frightened about whether or not they should be tested and whether or not they should have screenings. So the short answer is that BRCA is not a commitment that you will get cancer, but it also doesn't increase your risk of dying from cancer. So for example, we know that BRCA does not have what we call full penetrance, which means because you're a carrier of BRCA doesn't mean that you're going to get a cancer. There are some families where we see it skip generations. So in other words, you may have a line of siblings that I take care of that have cancer, but their children may not have cancer at all, even though they're BRCA carriers. We don't understand it. We're trying to learn about it, but it's really intriguing that that can happen. But let's take patients who do have BRCA. I mentioned the siblings, okay, that 5 of them that have cancer of various types. What we found for breast cancer, actually, is having BRCA does not mean that you're going to die from your disease any sooner or do any worse. So we really don't do anything more aggressive. We don't do more aggressive breast cancer surgery for those patients. We don't do more aggressive chemotherapy for those patients. Okay. But what we do now, within the last year, is we actually give them this anti-genetics drug, this PARP inhibitor, Lynparza, for women with early stage breast cancer as a maintenance for a couple years to make sure it doesn't come back. So at the end of the day, my BRCA patients, I have several in my practice that were BRCA identified later in life but had breast cancer as early as 1985. Wow. Who now have had 3 cancers because they chose to keep their breast tissue and are alive and cancer-free with minimal therapy. So it's not a death sentence, but it's a way for us to better understand the risk that patients may have so we can be better at screening. And if we can change something to assure that they remain cancer-free, we want to be able to do that for them.
Now, we talked earlier today about how Lynparza it can be used in the prostate cancer setting as well. Is this an example of where we just kind of find out that something is effective against another cancer, or is it because there's a commonality between those types of cancers?
So it's more the genetics pathway that's common. Okay, so now we do testing for BRCA in the blood, which means you inherit that. But we also do testing on the actual cancer cell itself, because it may express BRCA and the blood may not. And sometimes I see it in both the blood of the patient as well as the cancer cell. So it really has to do with the genetics of the cancer cell, although the site of origin of the cancer is important because that affects other treatment recommendations, including surgery and sometimes chemotherapy or sometimes anti-hormone kinds of therapy.
Okay. Infusional chemotherapy, is that a Robin Zahn term, or is that something I'd find on Google?
That's something you can Google. You can find
you will
that.
find that on Google.
What is that? So is that, but I think you mentioned that that's done in the surgical setting, though. Did I get that right?
So to clarify, for ovarian cancer, we do what's called intraperitoneal chemotherapy. So in the surgical setting, and that's the only setting, there may be some extraneous cancers, but primarily that's done routinely by some institutions for women with higher risk ovarian cancer. So infusional chemotherapy, to extend on that, means chemotherapy we give through the IV. But over the many years, we've actually developed chemotherapy that's oral, and we've been using that for decades for breast cancer. So that's why I make the distinction between infusion, which is IV, and oral that can be taken at home. Okay, gotcha.
Well, this has been great. Thank you. We're really, really fortunate to have you here with us today. We were able to snag you as you were passing through town, which is good. So June, I guess this will run the first week of June. So now we're in National Cancer Survivor
Month.
So we'll do some special things for that. Maybe even have another survivor or two on. We've had a few of those in the past. But thank you again, Dr. Zahn, for being here with us today. It's been really, really nice. Thank you so much,
Steve and Jill. Really enjoyed our conversation.
Yeah, thank you. All right, so everybody, we'll be back here again next Wednesday at noon, and we'll look forward to seeing you then. Thank you.